We have discussed previously. Now we are discussing this individual disorder one by one. That is the benign and the malignant one, partial and complete mole, and the invasive choriocarcinoma, trophoblastic cell tumor. The difference, what is difference between partial and complete mole? Though these both are the benign one, the benign presentation of gestational trophoblastic disease. One of the common presentation very typical presentation or typical difference among both of these. There's the presence of fetal tissue in partial mole, not in the complete mole. In partial mole, when we see on histological examination and ultrasound, there is a focal changes only. In complete mole, the changes are generalized one. In partial mole, there is a less soiling of the trophoblastic cells tissues. In complete, there is more soiling. Partial mole, genetically, these are the triploid, most commonly, rarely tetraploid, rarely mosaic pattern. When in complete mole, this is the diploid. The patient with partial mole present very commonly with the failed pregnancy. They thought they're having a pregnancy because ultrasound also shows the fetal parts, and they start to bleed, and patient present to the hospital or doctor for the miscarriage or any kind of miscarriage, as she assumes. But she is having partial mole, that is because of fetal tissue. Along with the fetal tissue, trophoblastic abnormal tissue is also present. In complete mole, most common presentation is incidental finding on ultrasound, because patient whenever present to the hospital for the normal routine checkup or booking, she on that spot found to have a molar pregnancy on ultrasound, because there's a clear-cut picture for the complete mole. In partial mole, we sometimes become confused because of presence of the fetal tissue. The management for both of them is suction curettage. We'll discuss further. So let's discuss something about invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid cell tumor, which are the malignant counterpart of the gestational trophoblastic disease. Invasive mole most commonly arises from the complete mole. Okay, complete mole. Invasive mole always will arised from the complete mole. It having tendency to perforate the uterine myometrium, penetrate the uterine myometrium, but having a very less likely or less tendency to have a distant metastasis. As for its choriocarcinoma, this is very aggressive tumor, rapidly progressive. It usually 50% of the cases arises from the complete mole and less likely from the 25% from the non-molar miscarriage and 25% from the normal pregnancy. It is having very aggressive nature, but it is very responsive to the chemotherapy. The genetic material in choriocarcinoma is very variable, starting from aneuploid to the diploid, or any kind of genetic material may have present in choriocarcinoma. In placental site trophoblastic tumor and epithelioid cell tumor, they usually present the common features. Usually they are arising from the term pregnancy. They are following the term pregnancy, right? The both of them. These both arises from the intermediate trophoblast, which is not in case of the choriocarcinoma or invasive mole. Placental site trophoblastic tumor is usually presented with high amount of alkaline phosphatase and less amount of beta HCG. These are the difference of PSTT and ETT from the choriocarcinoma and invasive mole. So now, as we have discussed it, now move towards management, which we left initially. Before managing the patient, how to diagnose? As history suggestive of pregnancy, that is amenorrhea, may have vaginal bleeding, may have ultrasound report showing the molar pregnancy. Patient may present with certain kind of complication which we discussed in the clinical presentation. That is, may patient present with hyperemesis gravidarum, maybe with hyperthyroidism, maybe with excessive enlargement of the hypophyndus, maybe with the having ultrasound report showing the huge thecal uterine cyst, maybe anemic because of vaginal bleeding, maybe seizures or respiratory collapse, though very least likely, very rare presentation, but patient can present. Clinically, we may have found the patient with anemia, may have raised blood pressure, may have signs and symptoms suggestive of hyperthyroidism, maybe edema because of preeclampsia, maybe hypophyndus, maybe more than that, gestational age. Vaginally, patient may have passage of vesicles even. Then how to investigate? Investigation always divided into two parts. General investigation is specific investigation. General for baseline, for health profile, we are advising in every patient, that is CBC, blood group, viral markers, random blood sugar, and urine DR. If we have a notice, what changes could be present in the baseline investigation? Patient may have anemia, so HP may be low, may have a preeclampsia, the platelets may be low, right? And among a specific investigation divided into again biochemistry imaging. Biochemistry, the beta HCG, it will be even up to more than 2 lakhs expected for that gestational age. May have a raised thyroid profile, abnormal thyroid profile, right? May have electrolyte imbalances because of hyperemesis gravidarum. So an imaging ultrasound which shows the molar pregnancy, may be showing fetus. If there's a partial mole, may not be if there's a complete mole. On Doppler imaging, patient may show the invasive nature, as in case of the invasive mole. X-ray may be advised to suggest to see the metastasis in every patient. But if we are suggesting the advanced disease, maybe imaging can be advised further. Now, how to manage, right? In every patient, management starts with the registration. We have to register the patient. Where? At the cancer centers. Wherever we found cancer centers, for example, in Nawabshah there's a Noreen center, in Karachi there's a Kiran center. We have to ask the patient for the registration first, because if patients are registered, we come to know after the follow-up the whoever needs chemotherapy and whoever do not needs the chemotherapy, because only 10% patient needs the chemotherapy, and whenever they needs chemotherapy, 90% patient having the 100% successful outcome. So we should know whoever needs chemotherapy, and how we can know? By registration. Then after registration, stabilize the patient, manage the patient according to signs and symptoms, and prepare for the specific treatment, that is suction curettage. For that, we have to counsel the patient, we have to involve the multidisciplinary team, that is involvement of the sonologist, involvement of the hematologist, blood bank porters, OT personnel, senior anesthetist, senior obstetrician, right? And whoever the person needs in preparing the patient for suction curettage and managing the patient will be a part of multidisciplinary team approach. Then we go for the suction curettage, which is this ideal treatment for the patient with the molar pregnancy or any kind of the malignant or benign conditions. But if patients having the partial mole which deters the suction evacuation or suction curettage, and that patient with well-formed fetal parts, we can advise the medical termination as well. Whatever the tissues we found, we must have a histopathology for that to confirm whether it is a benign or malignant, because in previous slide we discussed the how to diagnose, and we discussed the history, clinical examination, investigation, but accurate confirmation will be on histopathology. What type of the molar tissue is there? So after every suction curettage, we send the this tissue for the histopathology. Then suction curettage have been done. And now to decide whoever needs chemotherapy and whoever not. Here are some indication for the chemotherapy. After suction curettage, we put the patient on the follow-up. We ask the patient to have serial beta-HCG 2-weekly interval and show us, present to us at 2-weekly, right? And we should have a sight or eye vision over the beta-HCG, whether it's a rising trend, it's having a plateau, whether it is raised or it is subsiding. If patient is having the rising trend of beta-HCG, we ask the patient to come on the 2-weekly interval and we are seeing that patient beta-HCG is raised before the previous one. There is an indication for chemotherapy. But if there is a plateau for the beta-HCG, whatever the level amount of the beta-HCG is patient having, but it persists on 3 visits, 2 weekly apart. This is also indication for chemotherapy. For example, a patient present to us after 1 month at 4 weeks and still her beta HCG is more than 20,000. There is indication for chemotherapy. If patient is on the follow-up and even at 6 months she is having the raised beta HCG, though it is declining, but even raised beta HCG at 6 months, there is indication of chemotherapy. And if we found histopathological evidence of malignancy after taking sample on suction curettage, there is indication for chemotherapy. And whenever there is a suspicious or confirmation of the metastasis, again patient needs chemotherapy. So these are certain indication where we have to start the chemotherapy. Then how to give chemotherapy? For giving chemotherapy, we have to divide those patients who are fall in a category of need for the chemotherapy into the two groups, low risk and high risk. If we are advising, yeah, we are doing certain scoring system in a patient, right? If that score is less than or up to 6, the patient fall into the low risk category. But if it is 7 or more than 7 score is there, patient needs high risk. Patient falls in high risk scoring. So the basic purpose of dividing the patient into low risk and high risk is that the type of chemotherapy providing to these patients. In low risk patient needs only single agent chemotherapy, most probably, and high risk, the multi agent. Okay. And here is a WHO prognostic scoring system. On that scoring system, we divide the patient into low risk and high risk, whoever needs chemotherapy. And there are certain eight variables, right? Age, pregnancy history, what was the last pregnancy, and how many months are from the last pregnancy, what is the initial beta HCG level, the size of a tumor on ultrasound, whether metastases are present or not, if present, the number of metastases, whether previous treatment is given or not. These are the eight variables on which we are deciding or scoring the patient. And score given is 0, 1, 2 and 4 by certain characteristics or the variables, right? So if a patient having a score of 6 or less, patient fall into low risk category, and if it is 7 or more, patient fall into the high risk category. In low risk category, we advise the patient initially on methotrexate. Methotrexate is an antifolate anti-cancerous drug and it very effectively treat the condition. Here in the low risk, 100% successful rate have been seen. Initial management is given in the hospital because patient may bleed. But if patient do not respond to methotrexate, then what we advise? We advise the actinomycin D. But if beta HCG is more than 300, then instead of actinomycin D, we advise the immunotherapy. Immunotherapy, actually these are mnemonic for the multiple chemotherapeutic agent, E for the ectoposide, M for the methotrexate, A for actinomycin D, C for cyclophosphamide, O for oncovarin. We are not going into very detail of these types of chemotherapy. We are just we will be just flow superficially. So in high risk patient, we start treatment with immunotherapy, but if resistant to that, then IPIMA or TEP therapy. IPIMA, that is ectoposide, cisplatin, P for platin, cisplatin, then again ectoposide, M for methotrexate, A for actinomycin D. Then T for Taxil, paclitaxel, E for ectoposide, T again for taxil, paclitaxel, and P for cisplatin, right? And along with these type of chemotherapeutic agent is given, patient should be on strict follow-up 2 weekly apart. And chemotherapy is given till beta HCG is normalized. Even after normalization, 3 cycles further chemotherapy is given to abolish any residual trophoblastic diseases. So, what are the side effects of this chemotherapy? As we know, the most of the chemotherapeutic agents having the same kind of side effects as mucositis, pleuritis, raised liver function test, elevated bilirubin, right? And even these also having the secondary type of malignancy rarely, but on after a long exposure to the chemotherapeutic agent. What are the effects on the fertility? If chemotherapy is giving around the age of 40 or more than the age of 40, then having a profound effect over the ovarian aging. It accelerates the ovarian aging and menopause. Generally, it is said that it, if in low risk patient, when we are giving the methotrexate only, patient is having the early menopause 1 year, and if patient is having the high score and patient is taking IMACO or APIMA or TEP therapy, patient may have early menopause more than 33 years, right? But around the age of 40 years, patient having a profound effect over the menopause, right? What kind of contraception can be given to the patient? Till the normalization of the beta HCG, we are advising the barrier method to the patient. After normalization, any kind of method of contraception can be advised. Before normalization, usually hormonal contraceptive and intrauterine contraceptive devices are contraindicated. Intrauterine contraceptive devices are contraindicated because of the risk of perforation, and hormonal uh, tablets or injection, whatever in form, is also not given because of the effect on the beta HCG level. So we may have a confusion regarding whether disease is progressing or whether the patient is having effect over the beta HCG because of the hormonal status. Okay. Then we'll discuss whoever the patient in management may needs evacuation repeated or may need hysterectomy. The only indication in a patient after suction curettage and after follow-up if needs second evacuation or repeat evacuation is that when patient heavily bleeds and become hemodynamically unstable in this, and there's a ultrasonographical evidence of the trophoblastic tissue. So this is the patient who needs repeat evacuation. Okay, means the only indication in which patient needs repeat evacuation is that heavy bleeding with vitally unstable patient with tissues over the ultrasound. Otherwise, no indication for repeat evacuation. Now, what are the indication of the hysterectomy? If patient having completed family and there is a recurrent bleeding, patient want to permanent treatment, then patient can be opted for the hysterectomy. Or there is a placental cytofibroblastic tumor, epithelioid cell tumor, and which is not chemosensitive, the patient is having needed hysterectomy. Then what is the follow-up? How to follow up the patient? For benign, it is different. For the malignant, it is different. For benign, after partial mole, if and patient is having the serial monitoring of the beta HCG 2 weekly apart, if we found to have a normal beta HCG level, at least 1 month apart, two values are normal, we can omit, we can stop the follow-up. But in case of complete mole, when beta HCG, we are advising 2-weekly interval, beta HCG is normalized within 56 days, all about around 2 months, it become normalized. If then we have to prolong the follow-up for 6 months, but after the date of suction curettage. One thing is that. Second thing, if the beta HCG normalize after 56 days, then the follow-up will be also extended to 6 months, but after the date of normalization, we have to monitor. Okay. In complete mole, when the beta HCG normalize within 56 days, follow-up will be for 6 months from the date of suction curettage. But if beta HCG normalize after 56 days, the follow-up will be 6 months from the date of normalization of beta HCG. Then for malignancy, what is the follow-up? For malignancy, follow-up is lifelong. Initial, more frequently in blood along with the urine. Then with the passage of time, if beta HCG normalize, then frequency of this follow-up will be reduces, but still in the follow-up. Initially 1 monthly, then 2 monthly, then 6 monthly, then yearly. But after 2 years, we ask the patient to only have a urinary beta HCG at regular interval, but it will be the lifelong. So here we ends our lecture. If you have any query, you can send me on my WhatsApp, on my email. Okay, thanks a lot. I hope it will be beneficial for you.